I'm Dr. Fath Abdelbaki, Professor ENT, Alexandria Faculty of Medicine, and I'm going to present on physiology of hearing. By the end of this lecture, you should know the characteristics of sounds, the different anatomical parts of the ear, the external ear, middle ear, and inner ear, as it relates to hearing. And you should acknowledge the role of each of these parts in the mechanism of hearing. And at the end, we will have a small talk on clinical application, on practical clinical applications. Sound characteristics, usually sound is produced by any vibrating body. When any vibrating body has compression and rarefaction. And this alternate compression and rarefaction is usually behind the production of sound. So sound can be defined as an audible wave of pressure propagating through transmission medium. There should be a medium transmitting these pressures of compression and rarefaction. This medium is usually air. It could be liquid or solid, but usually it is air. Sound has three main characteristics. The first characteristic is the pitch. It's the number of cycles per second, and it can be called the frequency of the sound. The frequency of sound, it could be a low frequency or it could be a high frequency sound, like the cry of a child. The second parameter is the amplitude, the intensity of the sound, how far it is loud. Is it soft, like whisper, or is it loud? Pitch is measured usually in unit which is called hertz, and the intensity is usually by measure called decibel. The third parameter, is this sound pure tone or there are overtone? What is the quality of the sound? But usually we take care of the first two, the pitch and the intensity. Going to the basic anatomy of the ear. An ear, as you know, is three parts: the external ear and the middle ear cleft and the inner ear. The external ear constitutes mainly of the auricle or the pinna. What is outside this area is called the auricle or the pinna. And then this auricle or pinna continues as a canal. This canal is the external auditory canal. So when you say external ear, you mean the auricle and the external auditory canal. And the external auditory canal is formed of two parts, one cartilaginous toward the auricle or laterally, and osseous part which is toward the middle ear. And the external auditory canal ends by the tympanic membrane. And the tympanic membrane will have two surfaces, at least two surfaces. One surface toward the external ear and is lined by skin, and the other surface towards the middle ear, and this is lined by mucous membrane. Moving to the second part, which is the middle ear cleft. And the middle ear is mainly a cavity, and the cavity should contain air. Why air? Because the vibration of the tympanic membrane will necessitate the presence of air on both sides. Of course, the air is coming from the environment to the external ear, but it stops at the tympanic membrane. So the main constituent of the middle ear is air. Inside the air, there will be the ossicles. We have three ossicles. These ossicles are very tiny ossicles, and it will start with the malleus. And as you see here, that the malleus, there is a handle of malleus which is attached to the tympanic membrane. And the malleus then will be related to the incus, and the incus will be followed by stapes. What you can see here that the stapes is lying in the foot plate with its foot plate on the oval window. So when the tympanic membrane will move, the malleus will move, transmitted to the incus, to the stapes, to the oval window, and this movement will be transmitted to the inner ear after that. The oval window is the medial wall of the middle ear, and this medial wall separates the external ear, the middle ear from the inner ear, and it has two windows, one up, which is the stapes, and one below, which will be called the round window. As we mentioned, the presence of air is important for hearing. From where this air comes? This air comes from the eustachian tube, from the back of the nose. Another components in the middle ear, another structure present in the middle ear are the muscles. We have two muscles. One of them is attached to the handle of the malleus and will be called the tensor tympani. And the other is attached to the stapes and will be called stapedius muscle. These two muscles will reflex only with loud sound when the sound is above 70 decibel. Here we speak about decibel, and which is unit of the intensity. And the main function of this is to protection of the inner ear from high sound. So if there is a continuous loud sound, the tensor tympani and stapedius muscle will contract, preventing this sound to damage the inner ear. The inner ear is termed labyrinth. When you see the labyrinth, we mean inner ear. So if we speak about labyrinthitis, inflammation of the inner ear. Labyrinthectomy, removal of inner ear. And the labyrinth has two main parts, divided here by an imaginary line. In front of this line, there will be the cochlea, which is the organ of hearing. And behind this imaginary line, there is a vestibular system, which is responsible for maintaining our equilibrium. The main structure of the labyrinth, whether in the cochlea or in the vestibular system, is the membranous labyrinth. This is where the hair cells are present. This is where we can hear, where we can maintain, we have the receptor to maintain our equilibrium. This is the membranous labyrinth. But because this membranous labyrinth is very fragile, it is protected by the bony labyrinth. So the labyrinth, whether cochlea or vestibular system, we have membranous labyrinth, which is present inside the bony labyrinth. And in each of these two labyrinths, there is fluid. One inside the membranous labyrinth, which will be called the endolymph, and one between the membranous labyrinth and the bony labyrinth, it is surrounding the membranous labyrinth, will be called perilymph. So inside the membranous labyrinth, the fluid is called endolymph. Outside the membranous labyrinth, it will be called the perilymph. If the cochlea is 2.5 turns, and if we uncoil this cochlea, it will be like a tube. And this tube will have 3 chambers. Chambers is called scala. When you see scala, is a chamber. So we have 3 tubes, tubes with 3 chambers. The one in the middle will be called scala media. Here there will be presence of the organ of Corti, the organ of hearing. Above the scala media there will be scala vestibuli, and below the scala media there will be scala tympani. What you notice in this picture that the scala vestibuli and scala tympani are communicating with each other. And the second observation, that the scala vestibuli starts by the oval window. And remind you that the oval window is closed by the footplate of the stapes, by the ossicle, whereas the scala tympani will end by the round window membrane, where there are no ossicles here, and it's only a membrane. So we have three chambers, two of them communicating with each other, the scala vestibuli and scala tympani, and both of them are surrounding the scala media. So which fluid will be there? The perilymph. Whereas the scala media will have inside it, because this is a membranous labyrinth, this will have inside it the endolymph. And the scala media is a closed tube, and the fluid inside the scala media, which is the endolymph, should not communicate with the perilymph, otherwise there will be pathological disease and problems. Here again, to recapitulate, we have in the middle the scala media, or the membranous labyrinth, where there will be the organ of Corti, the organ of hearing. Above the scala media, there will be the scala vestibuli, starting by the oval window, and below there is the scala tympani, which ends by the round window membrane. And the scala vestibuli and the scala tympani are communicating with each other. The fluid, as we mentioned, number one is the perilymph, whether it is up in the scala vestibuli or down in the scala tympani. And in the middle, there will be the scala media with the endolymph. So the fluid, perilymph in scala vestibuli and scala tympani, endolymph in scala media, and a third fluid, which is the cortilymph, or the fluid inside the organ of Corti, which resembles the perilymph in its structures. You should know always, you should remember always that the perilymph is poor in potassium. PPP. Perilymph, poor potassium. And the endolymph is rich in potassium. And as we mentioned, these two fluids should not mix together. If we go to the main structure of hearing, this structure will be called the organ of Corti. The organ of Corti, it's named after the man who described this part. And the organ of Corti, as you can see in this picture, is present in the scala media. If we have a close-up view on the organ of Corti, we will see that the main structure is the basilar membrane. The basilar membrane is the membrane which separates the scala media up from the scala tympani down. And on this scala media, there will be the inner hair cells, which is responsible for hearing, and the outer hair cells, which has another role also in hearing. And both hair cells will have stereocilia, and this stereocilia will be attached to the tectorial membrane above the hair cells. So again, the basilar membrane towards separating the scala media from the scala tympani. Hair cells, whether outer hair cells or inner hair cells, and hair cells have stereocilia. The stereocilia will be attached to the tectorial membrane. And the impulses then, the impulses will go through the cochlear nerve to the brain to be transmitted for understanding speech. The hair cells are attached in rows. There is outer hair cells. We have 3 rows for outer hair cells and only 1 row for inner hair cells. But the inner hair cells is the most important for hearing. This is an inner hair cell with the stereocilia in its upper part. Each hair cell has about 100 stereocilia, and you can observe that this stereocilia, there is one usually long and the others are short, and these stereocilia usually move as one unit collectively, either towards the long cilia or away from the long cilia. This is the outer hair cell, and you can see here that the stereocilia are more or less the same length. And the function of this outer hair cell will be tuning. So we hear by the inner hair cells, and the sound is tuned by the outer hair cell. This will bring us to the hearing physiology. The hearing physiology, the hearing mechanism, usually the sound start by the external and middle ear receive sound, and they will magnify the sounds so that they stimulate the inner ear. The receptors here depend on movement, so these are mechanoreceptors. And the inner ear will discriminate the frequencies, and then they will transmit the auditory information via the auditory nerve to the CNS, where the brain will understand meaning and speech. The external ear. The external ear has three main acoustic functions, but it's mainly for sound collection. It's a tube for collecting sound. It has a role of some magnification, but not like the middle ear. It increases pressure on tympanic membrane, but to a less extent than middle ear. One of the main important functions of the external ear is localization of sound. So you know from where the sound comes. Is sound coming from your right side or from your left side? So the pinna and the external auditory canal, one of the functions is to collect sound to reach the tympanic membrane. The external auditory canal is like a tube, and the tube has one end which is open and the other end is closed. If this tube is placed in a sound field, of course the pressure will be low at the open end and will be high at the closed end. This is what we call the increased energy over the tympanic membrane. Sound localization, as we mentioned, if you hear a sound, you want to know from where it comes, from your right or from your left. And this is a function of the external ear, because the sound will reach the ear nearest to the sound. And of course, the intensity of the sound near to the sound, nearest in the ear nearest to the sound will be higher than the other ear, and because the head is acting as a barrier. So sound localization will depend on the time difference when the sound arrives to the ear, and on the intensity difference because one sound will be higher than the other. Now we move to the middle ear function for sound. There is a problem. There is no problem of passing sound from external ear to the middle ear. Why? Because in the external ear and middle ear there is air. But the problem is the passing of sound from the middle ear to the inner ear. Why? Because we said that the middle ear has air inside it. Whereas the inner ear, you remember the fluids in the inner ear, there is fluid in the inner ear. So we have air in the middle ear and fluid in the inner ear. So usually what happens is 99% of sound will be reflected back. And only 1% or less than 1% will be transmitted to the inner ear. This problem is called impedance mismatching. So how the middle ear will solve this problem? It will solve this problem by two factors or two mechanisms. The first one will be called acoustic separation function, and the second one will be called the transfer function. This is a diagram of the ear where you can see that the sound is coming from the external ear, moving the tympanic membrane, then moving the ossicles until it reaches the oval window. But it does not reach the round window at the same time. So there is a preferential for the sound to reach the oval window before the round window. So both windows are not stimulated at the same time. The sound reaches the oval window first by the ossicular chain, and this will create a pressure difference which is important for the movement of the cochlear fluid. And this is what we are going to call it the acoustic separation function, meaning that the sound reaches one window before the other via the ossicles. This is the impedance mismatching. There is air and there is fluid, so the sound will be reflected back. In normal situation, sound will be reflected, but if there is a mechanism which will increase the sound in the middle ear, it will be reaching the inner ear in a good way. This mechanism will be called the transfer function, the second mechanism. So we have seen the first mechanism, which is acoustic separation function. The second mechanism is the transfer function. The transfer function depends on two mechanisms. The first is the hydraulic action of the tympanic membrane. You can notice clearly that the sound vibrating on the tympanic membrane on a large surface will be concentrated to vibrate on the foot plate, which is a small surface. The ratio between the tympanic membrane and the foot plate is about 17 times. And this will increase the sound at the foot plate enormously. This is the hydraulic action of the tympanic membrane. The second mechanism is the lever action of the ossicles. All of us know the lever action. And here the lever is between, we have said that we have the malleus with the handle of the malleus, and we have the incus with the long process of the incus. The handle of the malleus is longer than the long process of the incus. By the mechanism of the lever action, there will be magnification of 1.3 times. So the lever action of the ossicles and the hydraulic actions of the tympanic membrane and foot plate, both of these will constitute the transfer function. The net result will be 17 times in the hydraulic action and 1.3 in the lever actions, making them, the net result is 22 times magnification to overcome the impedance mismatching. The impedance mismatching, again, between air in the middle ear and fluid in the inner ear. We have discussed the function of the external ear, and we said that the main function is collection and localization of sound. The middle ear's main function is to magnify sound by the mechanism we have said. And now we come to the most important one, to the most critical one, which is the inner ear. And the inner ear will have the role of transmitting the sound which have reached the oval window to the hair cells, and then to convert this sound which is a mechanical sound, to action potential in the auditory nerve, to the nerve impulse, from mechanical sound to nerve impulse, which this process will be called transduction. So we have transmission of sound and transduction of sound. The transmission function, this again, the tympanic membrane is moving, handle of malleus, the head of the malleus, the incus, the long process of the incus, the stapes, to end at the oval window. And what you can see vibrating is the basilar membrane. The basilar membrane is present in the scala media. Above the basilar membrane will be the scala vestibuli. And below the basilar membrane, there will be the scala tympani. And as you can see, the scala vestibuli up and the scala tympani down, both of them are communicating together. And you can see that the foot plate of the stapes is vibrating over the oval window, whereas in the round window membrane below the movement there is a membrane. There will be no ossicles here, so that to give the membrane the freedom to move to accommodate the pressure coming. This is the movement of the basilar membrane will stimulate the organ of Corti, and we will see what's going to happen later on. You can see also, you can appreciate also in this picture that the movement in the basilar membrane in the different parts of the basilar membrane, from the base near the stapes to the apex at the end, at the open end where the scala tympani and scala vestibuli communicate. Depending on the site where the basilar membrane is maximally stimulated, the frequency will be determined. So in the first row, you can see that the movement is at the apex. So this will be called a low frequency. In the middle one, you found that the highest frequency is in the middle. So we are going to call it in the middle frequency. And at the third row, we can see that the movement is maximally at the base, and this will be called a high frequency sound. But as we mentioned, the main function is the transduction function, is to convert these mechanical sounds to electrical impulse. To understand this mechanism, we can revise again the organ of Corti. We have the basilar membrane, which will be moving up and down. This movement will move the hair cells and the tectorial membrane above the hair cells, which will move to and fro. There is to and fro movement of the tectorial membrane. And when this tectorial move to and fro, it will stimulate the stereocilia of the hair cells at the apex of the hair cells. This will lead to bending of the hair cell cilia, and this bending of hair cilia will open and close the potassium channel gate, as we are going to show now. This is a diagram of the stereocilia over the inner hair cell. We can see here the short cilia. The short cilia. Above the short cilia, there is what we call the tip link. The second cilia is the long cilia. Remind you that there is one long cilia over the hair cell, and the rest are short cilia. And at the upper part of the long cilia, you can see the potassium gate, and here you can see that the potassium gate is closed. These cilia, which are present above the hair cells, are bathed in the endolymph, because, as we mentioned, the endolymph is present in the scala media. Whereas the body of the hair cell is surrounded by perilymph, but the cilia are surrounded by endolymph. You remember we said that the perilymph is poor in potassium and the endolymph is rich in potassium. So you will see the potassium surrounding the stereocilia. But up till now, the potassium is outside the cell because the gate is closed. If the cilia moves toward, the short cilia move toward the long one, there is a bending of the long cilia. What is going, as in this picture, what is going to see is that this tip link will be stretched. And when it is stretched, it will open the gate. And opening of this potassium gate will lead to the influx of potassium inside the cell. Again, here we will start by the influx of potassium inside the hair cell, inside the inner hair cell. And when it goes to the inner hair cell, it will depolarize the hair cell. This depolarization will allow calcium to enter the inner ear from the surrounding fluid. And when calcium is inside the air, it will stimulate the release of the neurotransmitter, the glutamate, which will stimulate the auditory nerve. So now the mechanical movement have been transduced to electrical impulse to the auditory nerve. In the resting case, usually the stereocilia are in a resting position, so most of the gates are closed. Maybe 10 or 20% only are open, but the rest are closed. If the cilia will bend toward the long one, there will be opening of the gate, allowing the influx of potassium and then the calcium, stimulating the nerve. But if the movement will go back towards the short cilia, the gate will be closed and there will be no stimulation at that time. So we have positive displacement towards the long cilia and negative displacement toward the short cilia. This is the hair cell, inner hair cell. Glutamate or neurotransmitter stimulate the spiral ganglion. Spiral ganglion has two poles, one towards the hair cell, which will be called dendron, and the other pole toward the auditory nerve, which will be called axon. So the spiral ganglion neuron has two poles, the dendrites towards the hair cells, the axons towards the auditory nerve to stimulate the auditory nerve. You remember the parameters? We have two parameters, the pitch, mainly two parameters, the pitch and the loudness. The pitch discrimination or the frequency will depend on where the basilar membrane will be stimulated. If it will be stimulated at the base near the oval window, this will be by the high frequency sound. If it will be stimulated at the apex, where there is a communication between scala tympani and scala vestibuli, this will be a low frequency. So here, the stimulation is at the base, so this is a high frequency sound. Here, the stimulation in the middle of the basilar membrane, this is a mid-frequency sound. And this is stimulation at the apex, this is low frequency sound. Remember this, the one in brown is the basilar membrane, above it the scala vestibuli, below it is the scala tympani. So the pitch discrimination will depend where the basilar membrane is maximally vibrating, whereas the loud discrimination will depend on how much this area will be stimulated. Again, the pitch discrimination is in hertz, and the loudness discrimination, the unit is decibel. Then we move from the first order neuron, which is a spiral ganglion, where there is dendrites near the hair cells, axon near to the auditory nerve, and this axon will go with the cochlear branch to the brain, to the second order neuron, which is the cochlear nuclei in the pons, and then it will cross to the opposite side to be the third order neuron in the inferior colliculus in the midbrain. So spiral ganglia, cochlear nuclei in the pons, and inferior colliculus in the midbrain of the opposite side, and it then goes to the auditory area. And the auditory area is present in the temporal lobe, in the superior temporal gyrus, in the temporal lobe, area 41 and 42. And then in the auditory association area, we can decode the impulses and we can understand the meaning. Some clinical applications. Of course, if there is any problem in hearing mechanism, the symptom will be the patient will complain of a hearing loss. And the hearing loss can be on one ear, can be in both ears. And the hearing loss, we have mainly two types. The conductive hearing loss, where the lesion will be in the external ear or in the middle ear. Here the problem is only conduction. The sound is not conducted in a proper way. And usually the causes of conducting hearing loss are treatable, whether by medical treatment or by surgical treatment. So the conductive hearing loss is not the big deal. The big deal if the problem will be in the cochlea, sensory or in the nerve, neural, and this is what we are going to call sensory neural hearing loss. Sensory if the problem is in the cochlea, and neural if the problem is the nerve. Until more 30 years ago, there was no treatment, no surgical treatment for sensory neural hearing loss. But now with the development of cochlear implantations, it does not cure the condition, it replaces the function of the cochlea. To some extent, to a great extent, it replaces the function of the cochlea. Back to our types of hearing loss, we have two main types, conductive hearing loss and the sensory neural hearing loss. And a third type will be called the mixed hearing loss. Example of a hearing loss, of a cause of hearing loss in the external ear, the wax. A common example, the presence of wax. Accumulation of wax in the ear. The patient, after swimming, he comes complaining of hearing loss. Why? Because there is wax which prevented the conduction of sound. An example of a problem in the middle ear, ossicular lesion, whether this ossicular lesion is due to trauma, whether it is due to infection here with necrosis of the ossicles, erosions of the ossicles, will result that there is ossicular discontinuity. The sound will not be conducted properly to the inner ear. So it will result in diminution of hearing, but not the total loss of hearing. Then example of hearing loss in the cochlea is the presbyacusis. Presbyacusis is degeneration of the organ of Corti, the degeneration of the hair cells there, and in old age, and this is one of the common causes of sensory neural hearing loss. Of course, there are other causes like trauma to the cochlea, like the acoustic trauma by sound, those who are exposed to sound. At one time they will complain of hearing loss. Example of cause in neural cause is the presence of a tumor on the auditory nerve. So these are some examples so that you can appreciate the causes of hearing loss. How do you know that the patient has a hearing loss? Of course, he's coming complaining of hearing loss, but we have to do some tests. One of the tests you should know is a tuning fork test. It's a clinical test. We mean by clinical test that you do it in a clinic by using simple measures like the tuning fork. And if you see that the patient deserves special tests, you refer the patient to the audiologist to have special test, whether pure tone audiometry or auditory brainstem audiometry, as we are going to mention soon. But what you should know now is a tuning fork test, because this test you can do easily in your clinic. You can see that we have tuning fork which can vibrate if we strike them. But when you strike the tuning fork, do not strike them over hard objects. You strike it over the back of your elbow. It will produce vibrations. And depending on the fork you are using, the vibration will be either 256 or 512 or 1024. You remember the unit? What is the name of the unit? Yes, it's hertz. So you have 256 hertz, 512 hertz, or 1024. Usually we use the 512 tuning fork to do our test in the clinic. Depending on the one who described the test will be named. The Rene test, we strike the tuning fork, we put it parallel to the air, so the vibration will move along the external auditory canal, along the middle ear. What is going to happen in the middle ear, it will be magnified, and it will reach the cochlea magnified. By doing that, we are speaking about air conduction. Now the patient is hearing by air conduction, and there is vibration and there is magnification of sound in the middle ear. Then you restrike the tuning fork back again, and you place it at the back, at the mastoid, just behind the tip, behind the auricle, and you place it, by placing it over the mastoid, this you are stimulating the cochlea directly without magnification. This we are going to call it the bone conduction. So we have air conduction and we have bone conduction. So Rinne test is comparing air conduction with the bone conduction in each ear separately. After finishing the right ear, you go for the left ear. So we have air conduction, bone conduction for right ear to see which is better, and then again in the left ear. So what do we expect? That the air conduction in a normal patient, what do we expect? That the air conduction is better or the bone conduction? The air conduction where there is magnification. The bone conduction, there is no magnification. What do we expect? Of course, the air conduction will be better than the bone conduction. And this what we will call it the normal Rinne or the positive Rinne, and this will be in normal ear. So when we say positive Rinne test, will mean that the air conduction is better than bone conduction. Now, if you find that when air conduction is less than bone conduction, although it's supposed to have magnification, there was no magnification. What this will mean to you? This will mean that there is a problem in the conduction system. There will be a problem in the external ear. There will be problem in the middle ear, either external or middle or both of them. And in this case, the Rinne is negative. And in this case, usually will diagnose a conductive hearing loss. The second test is Weber test. Here, Weber test does not test the air conduction at all. It tests the bone conduction. You strike the tuning fork and you place it over the bone in the middle. The most important, it will be in the middle. Whether it is in the forehead, whether it is on the nose, whether it is on the front of the teeth, but in the middle. What is supposed to happen? Suppose that the vibration will move in the bone to reach both cochlea at the same time. So in a normal patient, so this test first will compare bone conduction between both ears. Again, the Rinne, what does Rinne test? Rinne compare the air conduction with the bone conduction of one ear, whereas the Weber test usually tests the bone conduction and it compares both bone conduction in both ears. If the patient has normal cochlea on both sides, what do you expect? You expect that the patient will tell you that there is no lateralization. Here the term is no lateralization. There's no lateralization. He will tell you that he hears a sound in the middle. He does not hear the sound. He hears a sound on both ears. But the most important, that he is telling you that there is no lateralization, and this is the normal finding. Now, if the patient is coming complaining of hearing loss in one ear, in this example, this patient has a hearing loss in the right ear. And you place the tuning fork on his forehead. It was supposed that it goes to both cochlea. But if the cochlea on the right ear is diseased, the patient will not hear by this ear. He will hear by the better ear. So if the patient will tell you that he is hearing by the better ear, by the non-diseased ear, this will mean that the problem is in the cochlea of his diseased side. So in sensory neural hearing loss, the Weber is lateralizing to the diseased ear. Now, this patient, when we place, he's complaining of hearing loss in the right ear. And when you place the vibrating fork over the head, over the forehead in the middle, you will see the patient is hesitating. Why is he hesitating? Because he is hearing by his diseased ear. He's coming complaining that he does not hear by the diseased ear. But when you place this tuning fork, he is hearing by the diseased ear. This is why he is hesitating. So you have to explain to him to tell where he is hearing the sound, irrespective of whether it is diseased or not. Once he is assured, he will tell you that he is hearing by the diseased ear. Because the other ear has a good cochlea, he will hear by the other ear quite well. But in the diseased ear, there is a conductive hearing loss. This conductive hearing loss will prevent the environmental sound. When we sit an environmental sound, there is a background noise. This background noise will not reach the cochlea of the right ear because of the conductive hearing loss. And because of this, the cochlea here can appreciate sound better than the other side. This is a simplified explanations, but at least you can take it now that in conductive hearing loss, the patient will lateralize to the diseased ear. So if you see that the Weber is lateralized to the normal side, this is a sensorineural hearing loss. If it lateralized to the disease side, this is a conductive hearing loss. Just for your knowledge, when you refer to the patient for pure tone audiometry, it is the same principle. You can give the sound via headphone to stimulate the air conduction, and you can give it over the cochlea by bone conductor to simulate the bone conduction, and you ask the patient to signal whenever he hears sound. The advantage of pure tone audiometry is it is a quantitative and qualitative. So it gives you a quantity without going into details. There will be an audiogram chart, and in normal audiogram chart, the curves are usually at the top level. Whenever the curve you see it going down and down, this means that the patient is not hearing well. And these are the examples of conductive hearing loss, sensorineural hearing loss, and mixed hearing loss. Without details, you should know at this stage that the pure tone audiogram can differentiate between the different types of hearing loss: conductive, sensorineural, or mixed hearing loss. Also, it can tell you whether the hearing loss is in the low frequency or in the high frequency, because you can see in the chart there are the frequencies from 125 and its multiplication, 250, 500, 1000. When we speak about 1000 hertz, we speak about 1 kilohertz. 2000, we speak about 2 kilohertz, 4 kilohertz, and 8 kilohertz. And our range usually range from 125 to 8 kilohertz, because these are the frequencies which are appreciated by the human ear. And on the other axis, you can see the intensity. Remember the unit of the intensity? Yes, the decibel. You can see 0 decibel. When you say 0 decibel, does not mean 0, but it is the lowest level, and then 10 decibel and 20 and so forth. So the pure tone audiogram can tell you the type of hearing loss, the frequency of hearing loss, the degree of hearing loss. In cases of infants and young children, you have to know that these children will not cooperate. He will not tell you whether he hears or not. So this is why we refer to the auditory brainstem response. We put the child asleep, and we put sound stimulus in his ear, and we depend on receiving the waves reaching to the brain from the cochlear nucleus to the inferior colliculi to the midbrain. The waves which will be drawn will appear on the screen, and by this you can say if the patient or the child is hearing and at what level he can hear. I hope that you understood the presentations. At the end, I would like to thank you, and please do not hesitate to email if you have any questions on my email. Bye.